morning, everyone. You are very welcome to the HSE National Social Inclusion Office live webinar for International Overdose Awareness Day 2025. Now, without further ado, I will hand you over to your host for today, Dr. Dennis O'Driscoll, Independent Chair of the National Naloxone Oversight Quality Assurance Group. Thank you.
Good morning, everyone, and welcome to IOAD 2025. I'd like to thank everyone for joining this live webinar. And just a quick reminder before we begin that today's session is being recorded and will be available on drugs.ie. International Overdose Awareness Day is the world's largest annual campaign to raise awareness of overdose, reduce the stigma associated with drug-related death and harms, and acknowledge the grief felt by families and friends who have lost loved ones. It's a day dedicated to our shared call, time to remember, time to act. Thank you for those who've taken the time today to join our webinar, to remember those without stigma who've been died or have been harmed from overdose, and to acknowledge the grief and trauma carried by their families, friends, and communities. In Ireland in 2021, 354 people lost their lives through overdose, opioids accounting for the most common drug group of 7 out of 10 deaths. Worryingly, 41% of those who lost their lives were alone at the time of their death. These numbers remind us that every life lost is not just a statistic, but a person, and that drug overdose deaths are preventable. This year's theme is community driven by hope. Overdose not only shatters families, it fractures entire communities. Each fatal and non-fatal overdose ripples outwards, affecting people in countless ways. But we are one community, not only because we share the pain of loss, but because we share the power to change what can happen next. Today, we acknowledge the grief of families and friends who've lost a loved one through overdose and the pain that may suffer while listening today. The grief carried within our communities and by colleagues in support services. The impact of each non-fatal overdose, both for the person themselves and for those supporting them. We also extend our thanks to all of you here live and those watching this recording afterwards, to each Circle peer-to-peer program facilitator and to every 24-25 Circle graduate, congratulations, whose work may have already prevented overdoses and saved lives in their communities. To those who have been recognised and responded to overdose in their communities and saved lives. To our colleagues in support services across the country who continue to respond to overdoses and provide life-saving support. I had the privilege of beginning this journey back in 2015 while serving as Chief Pharmacist at the HSE Addiction Services. Some of you may remember the short video from that time. It's certainly a blast of the past. Thank you again to Nikki Killeen, Nikki Corrigan, and Dawn Russell for making it happen. So just so I can remember how youthful I was, here's our YouTube video. An unpublished report on overdose, we have decided to run with a naloxone demonstration project. This project is hoped to reach the more difficult populations of drug users and the provision of naloxone, which is not a lifesaver, but it gives time to keep people alive in order for an ambulance to arrive. And this is where the project is leading towards, with the availability of about 600 products initially and 600 patients initially into the whole program. It's hoped that this program will develop into a mainstream program and be run alongside other addiction programs within the Irish Addiction Services. In itself, as I said, naloxone currently is an injectable product. We are looking to get a more client suitable product, so I would be looking at a nasal product, which would be a much easier product for people to administer under pressure and stress rather than injectable. However, the product that we have at the moment is an injectable product, and our
whole training programme which is run in conjunction with the HSE, the voluntary sector, which includes Merchants Care Ireland and Illiffey Drugs Project, the National Family Support Network, and homeless services, the safety net being one of those, that we look to train up staff, workers, clients and family members and how to use this injectable product in 5 locations around the country.
Thank you so much for that. Looking at that, I would like to thank those who've stood with us from the very start, namely from the National Social Inclusion Office, Professor Eamon Keenan, Mr. Joe Doyle. I know for a fact that without the drive and enthusiasm from Mr. Tim Bingham, the Needle Exchange Programme, the GPs who prescribed the naloxone for us in the very first days for that pilot project, and also the organisation who definitely threw their weight behind the project because they saw the need for it at the time, the Anna Liffey Drugs Project, Novus, Peter McVerry, Merchants Quay, the homeless agencies, the Peter McVerry Trust, Ishka, along with the peers and workers who continue to strengthen this partnership, which we'll hear more about today in today's webinar. And of course, behind all of this was the political will of Ministers Leo Varadkar and Aidan O'Riordan, whose early support made the project possible. If I've missed anyone, I truly mean no offence. The strength of this initiative has always been in many hands, and the most important hands that it has been in is with the peers and the peer support workers. The project was evaluated and recommended for expansion, and today continues as an naloxone programme, a key initiative targeting the reduction of drug-related deaths and non-fatal overdose. When the programme began in 2015, I remember the budget was for 600 units of injectable naloxone. Last year, we had 6,944 naloxone preparations were distributed across the country, including injectable and intranasal forms, each one representing a life that might be saved. I think we should take this moment to acknowledge the lives that have been saved by naloxone across Ireland over the past 10 years. For today's webinar, I would like to thank the HSE National Social Inclusion Office for hosting this event, Minister Murnane O'Connor for providing the opening address. Each of our presenters will share vital updates and lead us in discussions about what comes next, all representing different parts of community. During today's session, we'll hear about updates in the naloxone programme and the work of Peer Naloxone Advisory Group, progress in the supervised injecting facility, naloxone partnership within the HSE clinic services, the Circle programme, naloxone training and provision for residents, overdose prevention within the prison setting. I want to sincerely thank each of our presenters for supporting this event, IMS for facilitating, and most importantly, each of you for being here together. Together we share the pain of loss, but also we share the power to act and the hope to change what comes next. Thank you. So I'd now like to introduce Minister Murnane O'Connor, the Minister for Public Health, Wellbeing and National Drug Strategy.
Good morning, everyone, and welcome to this very special event to mark International Overdose Awareness Day. I would like to convey special thanks to the HSE National Social Inclusion Office for organising this event, which is part of the annual worldwide campaign to raise awareness about overdose deaths. And I would also like to thank Dr. Dennis O'Driscoll, who is hosting today's event. International Overdose Awareness Day, observed annually on the 31st of August, is the world's largest campaign dedicated to ending overdose, commemorating those who have died without stigma and acknowledging the grief experienced by their families and friends. It is officially recognised by the United Nations Office on Drugs and Crime and continues to see growing global participation. We know that approximately 1,000 events are being held across more than 40 countries, drawing attention to overdose as a preventable cause of death and encouraging evidence-based responses. The theme of this year's event is Community, Driven by Hope. To all the families, friends and communities impacted by overdose deaths, we acknowledge your loss and your grief. We also recognise all our colleagues who work in treatment services, emergency services and hospitals across the country. They are often the ones who respond to overdoses and work hard to save the lives of the people they support. We acknowledge their hard work too. The latest data available shows us that there were 354 drug-related deaths in 2021. Most of those men and women were under the age of 45, representing lives which were tragically cut short. They will all be deeply and sorely missed by their loved ones, families and their friends. In 2021, half of the deaths were due to drug poisoning, the other half were from medical conditions, and more than half had a history of substance use or dependency. While each life lost is one too many, it is very significant that the number of overdose deaths has reduced by almost 20% from the previous year. This government is committed to provide a health-led response to drug use. We have prioritised targeted investment to ensure services are available to those who need them. I am committed to improving access to healthcare services for people who find themselves in these circumstances. The total allocated budget for drug services and inclusion health is $261 million in 2025. Funding was increased by 18% in 2025 compared to 2024, with the additional $40.5 million secured in budget 2025. As the theme of this year's event highlights, as a community, we not only share the pain of loss, but we also share the power to change what comes next. We are making solid progress in initiatives which can help people who find themselves in these challenging circumstances. We know that having a secure home really helps to stabilise people so that they can focus on accessing health care. This is why under the Housing First programme, 1,000 tenancies for homelessness people with complex health and social needs have been provided and a further 260 tenancies are planned. The new community care facility at Usher's Island for people who are homeless is a joint project between government and the Dublin Simon community to improve access to healthcare and services. The facility includes step-up and step-down beds for acute services and inpatient treatment beds for drug stabilisation and detoxification and recovery. The Department of Health has provided an additional $5.9 million to date to meet the operational costs for 51 beds in the new facility and is to incrementally increase capacity. This represents the largest single investment by the Department in Healthcare Services for people who are homeless and is equivalent to 10% of the total expenditure. The service will deliver approximately 700 treatment episodes by year across different clinical programs. This will increase the capacity to deliver treatment by 24% and increase referrals from hospitals and HSE addiction services by 26%. The increased availability to naloxone is another intervention to reduce drug-related deaths. The Department of Health continues to work closely with the HSE National Naloxone Oversight Group to highlight the benefits of naloxone and also to make naloxone more widely available. Professor Eamon Keenan will provide more in-depth information on the rollout of naloxone shortly. The establishment of a supervised injection facility has proven to be very effective, not only in preventing overdose deaths, but also by opening a pathway to recovery. Eddie Mullins will provide more details on the service later. Looking to the future developments, the Department of Health is working on drafting a new national drug strategy. To guide this process, I have brought together a steering group chaired by Dr. Sarah Morton. The group includes members of civil society, those with lived experience, government departments, the HSE, and the Health Research Board, and international experts. Their insights and recommendations will enhance the content of the new strategy and ensure it meets the challenges of the drug situation. The steering group has already begun its work that will be informed by the Citizens' Assembly on the drug use, the recently published independent evaluation of the current strategy, and feedback from consultations with stakeholders which were completed in the recent months. In conclusion, while we have made progress in reducing the number of drug-related deaths, we must continue with our efforts. To reduce harm and prevent overdose, we need to encourage people to get medical help if they feel unwell or suicidal after using drugs, and not to hesitate or delay because of stigma and fear. I want to acknowledge and thank those who work on the front line with dealing with drug overdose. To the hospital staff, paramedics, outreach workers, Gardaí, staff in homelessness, service and peers, thank you for the lives you save every day. When we all work together, we can prevent overdose deaths and improve outcomes for very vulnerable people. I wish you continued success in the provision of services to those who need it most. Before I finish, I would like to thank the other speakers that you will hear from today, including Andy O'Hara and Dr. Des Crowley. Finally, I would like to say thank you to all of you for attending this day of commemoration, and to extend my deepest sympathies to all of you affected by drug-related deaths and overdose. Thank you.
Thank you to Minister Myrnan O'Connor for her introduction to International Overdose Awareness Day 2025. I would now like to introduce Professor Eamon Keenan, National Clinical Lead from the National Social Inclusion Office, HSE, for his input and update on the naloxone programme, drug death data and drug trends.
Good morning, everybody. Apologies for not being with you today, and thank you to Dennis for chairing the International Overdose Awareness Day webinar for 2025. Although I can't be there, I thought it would be important that we could deliver an update on progress in relation to the naloxone programme over the last year. So we know the background to our naloxone programme. It's a programme that sits within Action 2.2.30 of our National Drug Strategy to continue to target a reduction in drug-related deaths and non-fatal overdoses. We know the most recent figures in relation to drug poisoning deaths in Ireland in 2021 were released, and that identified 354 deaths. Opioids continue to be the most common drug group involved or implicated in those deaths. And as a response to this, the National Social Inclusion Office is responsible for the expansion of the naloxone across communities to people who use drugs, to peers, to frontline staff, and to family members. Since last year, I suppose we've been keeping a close eye on emerging drug trends, and I know that we had a lot of concern around synthetic opioids, but just to say that they haven't presented as a very significant issue for us over the last year. We have noticed the presence of synthetic opioids in counterfeit tablets in a number of localized areas, and we have issued warnings and information in relation to those. One important thing to note in relation to the nitazene compounds was there's a lot of attention recently in relation to the amendments for the Misuse of Drugs Act, whereby HHC, people were aware, was controlled under the Misuse of Drugs Act as a Schedule 1 drug. However, it's important to note that 8 nitazene compounds were also controlled under that legislation. So that was a welcome addition to the Misuse of Drugs Act. In terms of naloxone provision, year on year, we continue to increase the number of units of naloxone that we distribute to the community. In 2024, we distributed a total of almost 7,000 units. And I suppose from our perspective, this has been a significant increase from the original naloxone pilot program, which distributed 600. So we've had more than a tenfold increase in the amount of naloxone that we've been able to distribute to people. It's split between the intranasal and the injectable. In 2024, we had over 4,000 intranasal products and over 2,500 injectable products. One addition in 2025, which is important to note, is now we have Ventazolve, or a new intranasal naloxone available. And in the first 6 months of 2025, 321 units of Ventazolve were distributed by the National Social Inclusion Office. Training has been a key part of our work over the last number of years. And I'm really glad to say that in 2024, training in relation to naloxone delivery really ramped up. And this was facilitated by the fact that we've been able to provide training on HEC Land Module 1 and HEC Land Module 2 training. And as you can see from these figures, that allowed us to increase training to a significant number of people during 2024. That training has continued in 2025, and it remains a commitment for the National Social Inclusion Office to deliver that training. Ultimately, the aim of naloxone distribution and training is to use it in overdose situations. In 2024, we had 438 administrations of naloxone reported to the National Social Inclusion Office. This is really good, really important. And what this really equates to is that we can say that for sure this has contributed to saving 17 lives. And I suppose it's not just individuals that are benefiting from this, but it's also families and communities, whereby our theme for this International Overdose Awareness Day is in relation to communities. So we can say that this has benefited communities and families and individuals over the last year. In 2025 then, we've had 183 incidents submitted to the National Social Inclusion Office. The vast majority of those have been in the Dublin region, with 2/3 of incidents. But the other two areas where we do see regular administrations of naloxone have been in Cork and in Limerick. And I'm going to make another plea here to all services that it's really important that you do inform the National Social Inclusion Office when an administration of naloxone occurs, because it allows us to give this information and to then lobby for increased resources for the programme. The gender breakdown shows that 70% were 69% were men. CPR was administered in 8% of cases, and Garda Síochána were present in 3% of cases, and 39% of people went with the National Ambulance Service or the Dublin Fire Brigade to hospital post-administration of naloxone. One of our big initiatives over the last 2 years has been the Circle programme. We're really happy to support and facilitate this right across the country, so that people are aware that the Circle programme is a peer-to-peer overdose prevention programme. In each programme, up to 8 peers are trained, and they're trained in relation to understanding overdose risks and being able to support the steps to prevent overdose and manage effectively if they are around individuals who do overdose. They also carry naloxone and then can administer naloxone. In 2024, we completed 16 programs, and that allowed us to say that 90 peers graduated in 2024 who were able to then be in a position to administer naloxone in an identified overdose situation. We've really continued to support this program, and a further 17 programs are being facilitated in 2025. Feedback from the program is really uniformly good. And you can see here some of the experiences and comments that people have. People really can say that they understand overdose risks and the arrangements that can be made for people in an overdose situation. And then the comments again are really supportive for it to continue to be rolled out to others. And there is maybe one for the facilitators to take on board, maybe less talking when the lesson is being delivered. We've continued to partner with services right across the country in the last year to facilitate naloxone training and administration. So this is just a selection of some of the services that we've partnered with over the last year. You can see there Ishka's in a number of the photographs, and they're a key partner for us in relation to our naloxone program. But we see there we have the DePaul Trust on Little Britain Street. We have Cork First Responders. We have Peter McVerry Trust. We have Cork Fire Brigade. We have then also Anna Liffey and the podcast that Jenny and Rob have delivered to Health and Wellbeing this week. So a lot of work was on behind the scenes that people don't necessarily see in relation to naloxone, and part of that is the legislation that's been enacted by the Department of Health. There's been 4 key pieces of legislation that have facilitated the expansion of the access to naloxone. Those statutory instruments are identified there, and they've allowed access to intranasal naloxone, access to training, and again, that pointed out the real benefit of that we saw in the numbers who were able to facilitate or access training on HSE land within 2024. There are still some legislation limits that we do need to address. For example, the independent access of naloxone for family members and others who may witness an overdose, as it's a prescription-only medication. Also, ambulance practitioners aren't in a position to leave naloxone with a person who declines transportation to the emergency department. And these are 2 key pieces of legislation that I think we really do need to address in our next national drug strategy, which is currently being worked on. And I'll commit now today to try and push these pieces of legislation so that we'll be able to have greater access to naloxone in the future. So that's really all I wanted to say today. I wanted to say a big thank you, first of all, to Jenny Smith for her hard work and commitment over the course of the last year, and indeed over the course of the last number of years, which has really enabled the programme to expand, to increase the access, and to meet our targets in the National Drug Strategy. Thank you.
Thank you, Professor Keenan, for that overview of the provision of naloxone, the intervention that and the positivity that naloxone can have, particularly when you see that from data that 17 lives were potentially saved because of the intervention of naloxone. I would now like to just share 3 slides with you about some recent events and initiatives that are being undertaken for International Overdose Awareness Day. So this last Monday on the 25th in the Mansion House in Dublin played host to a special celebration for honouring the graduates of the Dublin Peer Circle programme from an Liffey Drugs Project, the National Drug Treatment Centre Board, JAD in Tala, BCAT in Bray, and the DePaul Trust. The event was organised by Don Russell, CEO of Annie Liffey Drugs Project, and hosted by the Lord Mayor, Ray McAdam. This highlighting the commitment of the Lord Mayor to Dublin communities to support one another. The Lord Mayor not only praised the initiative, saying that it was a proof of strength of Dublin's communities, people stepping up to protect one another. The gathering recognised the achievements of individuals who had dedicated themselves, who have and are dedicating themselves to fostering safety, connection and mutual support within their communities. Mr. John Washington, a Circle Programme graduate, was there and he shared his experience, and Professor Eamon Keenan was there to thank for all those who participated in the Circle Programme. In the next slide, we have a programme that the HSE launched down in Cork ahead of Overdose Awareness Day by Dr. Dara Matthews in the HSE National Ambulance Services Alternative Pre-Hospital Pathway to launch a programme to give naloxone, the medicine designed to prevent to reverse an overdose directly to people who have overdosed in Cork but declined hospital transport. So a really important initiative, which Eamon had already spoken about in his presentation, about being a way forward so that National Ambulance Service workers can provide naloxone to people who use drugs who do not want to go with the ambulance. And the next slide is our own Jenny Smith, who had a really powerful, and I highly recommend that all of you look at this, with Rob Byrne from Aniliffe Drugs Project in conversation with Fergal Fox. It was a very powerful call for people to be involved with overdose prevention, and also it reminded us that behind every statistic is a human story, and with the right tools and understanding, lives can be saved. There is a link to the podcast which has now been shared in the chat. So just so you know that today is one part of other events that are occurring during the week by many other organizations across the country, and that being involved, demonstrating your commitment to the prevention of overdose is such a positive effect for communities. And I guess to reiterate what Eamon had said, to thank Jenny for being involved in that podcast. It's a very powerful podcast. And Rob gave fantastic insights into that podcast. Now, on that note, I would like to introduce Andy O'Hara, who's the coordinator of ISCA, who's going to give us a brief briefing on peer work within the community. Welcome, Andy, and thank you for being here today.
How are you, Des? How are you, folks? Listen, thanks for having us, and I'm just going to try and get my slides up here. So, I'm just going to get us back to the stop. Sorry. So, listen. Thanks for having us. And what I'm going to do is today I'm going to try and take us through a presentation which really looks at the connection between stigma and overdoses, and more importantly, how we prevent some of those. So we know from the research and our experience that stigma is a deadly force, but we also know that peer interventions can act as the antidote. But to do that, we're going to have a look at who has power within those relationships and get better at handing over power to peers so that they can lead in some of the stuff. So we know that there is evidence to support peer-led stigma campaigns. A recent survey across the island of Ireland identified that prejudice is a predictor for public support for deregulation of naloxone. And sorry, I'm just trying to Yeah, so we know that a recent survey across the island of Ireland identified that prejudice is a predictor for public support for deregulation of the naloxone supervised injected facilities and OAT treatment. But we also know that the survey also found that direct contact with people who use drugs can reduce prejudice, and we know that there is support for peer-led stigma campaigns to really gather support for overdose prevention policies. I'm going to give you a couple of quotes from research to show us what the evidence says. And what we know is there's a couple of pieces of research. The first one here that was published in an article in the Lancet, and it says the war on drugs has been a catastrophic failure and has generated a system of structural stigma for people who use drugs, which has been shown to contribute to the avoidable mortality of this. I can't read that. Sorry, the yoke on the side is in the way of this population. And then it also says that policies that criminalise drug use constitute structural stigma that contributes to health inequalities and increases the risk of preventable deaths among people who use drugs. These deaths are not inevitable. They are a direct consequence of policies that prioritise punishment over health. And that was in the American Journal of Public Health. And now what we see, we know that, some of the research as well continues to tell us that deaths are preventable. So the overwhelming majority of drug-related deaths are preventable. They are largely caused by the failure of governments to adopt and implement policies that prioritise public health and human rights, including the persistent stigma and discrimination that pushes people to the margins of society. And that was from an article that was published in the Global Commission on Drug Policy. So it's really shown you the evidence tells us that a lot of this stuff is structural and a lot of it is preventable. So how do we move from having a mentality where we see people who use drugs simply as the problem to as peers who are actors for change? So some of the work in which peers have developed in Ireland with ISCA is one of the things recently was a global day of action. There's a global day of action each year called the Support Don't Punish. And this year we the Ishka Peers designed a campaign. I suppose for support don't punish in 2025, we really wanted to really unpack criminalisation and the impacts of it. So we spoke to people who use drugs, family members, community workers, and legislators, really about the impact of criminalisation and why there is a more effective way to support people who use drugs, families, and our communities. And that was part of the international campaign. And that campaign is really about calling for drug policies rooted in health, human rights, and dignity. Now, to make all this possible, we have to understand that we need models and practices that are facilitated for us. What works for us is having an autonomous peer network. And if we're going to look at what the research says, we know that this stuff is structural. So it's very much not about just having peers just delivering initiatives or programs. It's about trying to really think about how do we have models and processes so peers can actually lead out on identifying the issues, developing the collective responses, and then implementing the social change. So if you look at the model here, on the left you have the circle, and it shows you the different activities we'd have, from outreach to research to training. And in all of those, the aim is to have a high level of participation and ensure that they're peer-led, which means that peers are involved in really the design, the delivery, and the evaluation of all of those activities. And then you're really in a stronger position to be able to influence decision makers making decisions, whether that's sitting on platforms, whether that's developing research or position papers. You're really strengthening your ability to be able to create the social change that we're all looking for. Like in this instance, we're looking to reduce overdoses and reduce drug-related deaths. So some of the examples of that work would be a lot of our peers have spoken at the Citizens Assembly. They also developed their own submission to the Citizens Assembly on drug use, which had 7 recommendations, which were really powerful, and most of them ended up, all of them ended up in the Citizens Assembly recommendations, and we'll be looking to see if they're in the National Drug Strategy. Hopefully they are. And then they also developed a position paper on how to reduce drug-related deaths, and that was very much informed by what was happening on the ground. So peers on the ground identifying issues around drug trends, developing overdose prevention strategies, and then that leading on to a position paper to really inform policymakers on how to reduce drug-related deaths. So the peer partnership or change model is very much around peers designing a process that allows peers to lead out, have the power, and create informed policies that lead to social change. And what we know from the research again is that peer work is effective in reducing overdoses and creating transformative change. And again, we know this from Ishka, but also the research tells us that autonomous peer networks can facilitate transformative change. And they do that by fostering authentic voice and agency, by countering stigma through collective power. And it's really about preserving the integrity of lived experience. And they do that through ensuring that the space always has the process always allows us to have authentic peer-led activism. And to do that, again, the research tells us, and from our experience, it requires autonomy. If you look at the picture over on the right, I think that's an example of another piece of peer-led work that speaks to some of the stuff we're speaking to today. You have 15 peers who are all people who are accessing Ishka, Merchants Quay, and the National Drug Treatment Centre, and they came together in a process which allowed them to kind of use photo voice to talk about their experiences of stigma, to try and get a real understanding of how it manifests. And what we got was a really powerful account of how structural it is, how embedded in our policies, our services, and our society it is, and also how best to address it. And I think some of the stuff they've spoke about is the broader social stuff like criminalisation and stuff, but also they've come up with 2 actions around developing a peer-led national campaign to address stigma, and also peer-led training that addresses stigma. But the key components to both of them is making sure that it's peer-led. And I'll just take you through a couple of pictures that were developed by the peers in the program itself, and each one has a caption. The one on the left, the caption that attached that picture was, "Women who use drugs can't ask for help. They have to hide the fact that they are addicted due to discrimination and stigma. We live in constant fear of losing our children," showing very much the impacts of it and how structural it can be. And then the second one has a picture there, and the caption for that is, "The nature is everyone around." So it shows us that if given a chance, from the roughest things, something delicate can grow. So we're moving on to kind of the positives and the solutions. And the last one there, the caption attached to that picture says, "The authorities stigmatized me because of my past, but anyone that knows me can see the change in me. This is a letter my kids made me, and the flower represents growth." And if you look in the top right hand corner, it says, "To Mammy, I love you so much and I'm so proud of you. I'm also so grateful I got to go on holidays with you. Thank you. Showing us what can happen and the power of what we can achieve if we give peers the space to become actors for change, not just in their own lives, but also in our society. And I'll just give you another snapshot of various partnerships we've done. So if you look over on the right, you'll see we've done some work with Peter McVeigh Trust and DePaul, and that was good because our peers had identified that there was some gaps in provision for peers who are accessing some of the homeless services. So we worked with Jenny Smith, who created partnerships with those services, and we're in there delivering peer-led naloxone training. And it must be said, actually, with some of their own peers who have been involved in the Circle program and then Merchants Key, we've had a massive role in kind of working with Merchants Key around the safer injecting facility. So we do a lot of outreach with them. We kind of try and inform the design, delivery, and evaluation of it. And I think it shows that I think what those two partnerships showed, that there's a recognition that there's a space for peers to have their own independent space, but then they have to come in and have a partnership with the services and the policymakers, because to achieve the change, we all have to be working together. And lastly, the Space Between project, which was a really good program that we ran with the HSE and the OAT clinics in CHO9. We've done a huge amount in the naloxone training with the clinics over the years. I think we trained over 800 people. Many people have went on to use that naloxone. But we wanted to really embed the learning and kind of build on the relationship building and try and solidify the partnership approach between kind of the people on the ground, i.e. the GAs and the Ishka peers. And we wanted to look at like what is the space between, and we wanted to address and recognise that there was a space between, because the space between really symbolises both, I suppose, the disconnection and really an opportunity to foster open communication in a real safe space. So we wanted to utilise the varied perspectives and lived experience really as an opportunity to transition, transform, and really build community connectedness. And they developed, you see on the right hand side, they developed a series of sculptures. And the sculptures were developed in collaboration with each other. So they partnered up to create each cast. And then they were given spaces to unpack more personal themes related to family, values, communities, personal and professional goals. And it was really an opportunity to process and share our stories and our art. So there was really, at the end of it, there was really a deeper understanding of what each community needs from each other. And there's an important story to tell, and I think it's consistent with the message here today. And that's about giving a voice to all, right? And the art installation did capture the barriers, the challenges, the stigma, the social determinants, and really the policies that have criminalised people who use drugs, but also where organisations, people, and structures are coming together to really look at efforts to create policy change, supports, and solutions along the journey. And I might just finish with a quote from Desmond Tutu. So he once said, "There comes a point when we have to stop pulling people out of the river. We need to go upstream and find out why they're falling in. And the people best suited to do this are those that have almost fell in, or that have fell in and climbed out, all from the stories of the far too many that never made it out." And I think what we've given you the description today is how independent, autonomous peer networks and a peer partnership for change framework really shows you how we can create the conditions for people who use drugs to use their experience and their invaluable analysis to redesign services, policies, and our communities, so we can really prevent deaths and improve outcomes. But vital to this work is that we create the spaces for us all to be able to recognise the role of peers, embed that into our practices, and be sure that we're partnering up at a policy level and on the ground to redesign services and to really influence policy, so that we can really get to the point where we're really reducing those deaths and building stronger communities. Thanks.
Thank you, Andy. What I've always said and will always support is the involvement of peers and the necessity to have peers involved with this whole program. As you said, I think the Desmond Tutu quotation explains it so clearly and articulates it in the best possible way, that those who have the lived experience, those who have the experience, need to be involved with that change and need to be involved with pushing that forward. Thank you so much, Andy, for that. I'd like to now take the opportunity to welcome Eddie Mullins, from the CEO of Merchants Key Ireland, who's going to provide us with an update on the medically supervised injection facility in Merchants Key. Thank you, Eddie.
Thank you, Dennis. Delighted to be here this morning, folks. It's a really great opportunity to talk about the success, I would say, of the medically supervised injection facility so far. I don't have control of my slides, so next slide, please. Just a little bit about Merchants Quay. We were established in 1991 as a homeless and addiction day service, and were the first organisation to introduce a needle exchange. And I think while the focus of my presentation will be on the medically supervised injection facility, it's important to note that MQI provides residential detox rehabilitation and aftercare services. We also provide prison-based addiction counselling services and community drug and alcohol services and family support. And I think the reason I mention them is because it's important to emphasise that drug treatment services are wide and varied and are required to be so. And no one facility or one service will help the people with complex needs. So it's great. Our organisation are delighted to be able to provide so many services. The supervised injection facility, as many people will know, was first, I suppose, mooted 9 years ago. And the minister with responsibility for drug treatment service at the time, Eoin Reardon, brought it to cabinet, and it was approved, and it went through a very lengthy process. And I suppose in some respects, while people were frustrated at the delays in implementing and delivering the service, what it did allow for was a very robust conversation and a very robust debate around the need for the service. So, I would say one of our key objectives is to bring our community along. We are based, as you know, in the north or the south inner city, and we have a very large, close residential population. And it was important and remains one of our priorities to work with the community to address issues that arise and to listen to their concerns. Next slide, please. So I've kind of covered the proposal for the injection facility was brought to government in 2015. It was legislated for under the Misuse of Drugs Act, and MQI won the contract. Won the contract to provide this service. Planning Commission was submitted in 2018, and Planning Appeal and Judicial Review, and most people will be familiar with the processes that we had to go through. The final granting of the permission was in December 2022. In 2024, we went to a tender very early on, about May in 2024. We were delighted to complete the project, the renovation project, and open late December 2024. Next slide, please. I suppose it's important to emphasize that the supervised injection facility is in a facility that provides many other services, and I think the supervised injection facility certainly complements the range of services that are available. So just some statistics there. We have a drop-in food service, and you can see in 2024 we provided over 81,000 meals, 4,000 showers, needle exchange, 22,896 visits, and nursing visits, GP services, dental services, mental health interventions. You can see the statistics on the screen there. And I think what makes it, what in my view makes the supervised injection facility a success is the fact that it's integrated with other vital services. So when a person uses our facility, they can access other services if they wish to do so, and if they're required to do so. So the overview: MQI, as I say, opened the MSIF in December 2024, and I suppose if you were to define it, it's a safe and controlled environment for individuals who inject drugs. It's much more than that, but that, I suppose, in its purest form is what we would define it as. And it's designed to reduce health risks associated with drug use, such as overdoses, transmission of infectious diseases, and also interventions, which I think are so important. Providing medical supervision and immediate care in case of emergencies. And I will give you some statistics on what has happened to date as we go further on. So what are the core services? I suppose injecting booths where clients can inject pre-obtained drugs under medical supervision, an immediate response to overdoses, aftercare and monitoring, emergency GP and nursing, and wound care and infection control. But also, the the opportunity to have a conversation with a person and to just sit and listen to their concerns and listen to their desires and their hopes. That's all catered for, and that's, you know, it's hard to quantify the importance of that. The support services, including our harm reduction education, including safe injecting practices, referrals to addiction, mental health, and other social services, provision of sterile injecting equipment, and health checks and advice, including testing for blood-borne diseases and then blood-borne viruses. And you know, we have had lots of situations where people have come in with one intention, maybe to use the injection facility, but then that opportunity has arisen to discuss another health concern that they've had. They've been able to have very dignified and private consultations with medical staff to support them on a journey that might be something that has concerned them, and that they've been reluctant to maybe access mainstream primary healthcare services. And this allows them that opportunity in a safe and dignified and private, confidential manner. So how does the MSIF ensure safety and quality of care? Well, there are safety protocols, strict safety protocols to manage overdoses, prevent the spread of infectious diseases, and ensure a safe environment for clients and staff. The quality assurance, regular staff training, ongoing service evaluation, and adherence to best practice guidelines. And again, data collection and monitoring is vital. This is a pilot program, as most people will know. So it's very important that we are able to provide clear evidence of the importance and the life-saving nature of this service, the impact, and the impact for both clients and communities. So we're very conscious that the data we collect will strongly support the case for mainstreaming this service as we go forward. Next slide, please. So just to give you a kind of a flavor of what the facility looks like, it is in the basement of Riverbank, and obviously basement areas, there are limitations to what we can do, but I'm very pleased that we provided a very nice, welcoming space for people to use, albeit it's in the basement, so natural light is obviously is very limited. But I think we've done a reasonably very good job in providing a nice, welcome and warm facility. So the first point of contact will be our reception area, where a client will come in, meet one of our project workers, maybe a member of the nursing staff, and it's usually quite a brief engagement. Person will show the drugs they have, and quite unusual. And I know in the very early days there was a reluctance from clients to show the drugs. There may be concerns about, why am I showing the drugs? But that became very normal part of the routine. And I suppose the reason for that is to ensure that a person has drugs when they come in, which is kind of a unique situation to find yourself in, because if you don't have drugs, you can't use the facility. And clients would give some personal details and very quickly move on into one of the injecting booths, which, as you can see on the screen there, is quite a clinical environment. It's a bright area, and it's clinical for safety reasons. And when the person goes into the injecting room, they will be provided with the various sterile equipment that they need. There's a variety of syringes and various other equipment available to the client. And we also have what we describe very bluntly as a vein finder, which is a piece of apparatus that will support a person who has difficulties finding veins. And I think what we found there is some of the frustrations clients have in not being able to find the vein. This piece of equipment has reassured them and helped them in that respect. So it's a very important piece of equipment. And obviously throughout the process, then when a person is using the booth, we have our project workers and nursing staff there to monitor and support that person throughout that process. And then obviously the overdose management, which is a key piece of the support and the medical attention that's available for people. We have obviously, you can see in the screen there, our we'll call it our trolley of support apparatuses, where we have naloxone and oxytocin therapy available to people if the need arises. And of course, then throughout that process, the nursing staff and medical staff can support clients around wound evaluation and other primary healthcare supports. Next slide, please. So when a client has used the facility, the injecting room, they will move on to the aftercare area, which, as you can see, is a very welcoming space, and the idea is that our project staff, our project workers and our nursing staff can observe the after effects after a client has injected their drugs, and we can keep a close eye on the impact, and if interventions are required, we can attend to the clients if needs be. It's also a space, and I think this is really important, where relationships are built, where people can have conversations and just talk about life and what their hopes and aspirations are. And it's a really good opportunity for our staff to get to know our clients better. We provide them with tea and coffee. They make their own tea and coffee, the sandwiches, fruit, yogurts, just general food, snacks that people would like to take. Of course, if a client wants to have a fuller meal, they can go upstairs to our open access area and have a meal there. And I suppose the service numbers that I'm going to give you now are to July 2025, and they have grown significantly even through the month of August. But we have had 954 unique clients use the service up to July. That's over 1,000 now, over 7,475 visits. 73% of the drugs used were heroin, 8% crack cocaine. And what's really interesting there is I'm presenting to you today from Scotland, where we attended the Scottish Drugs Forum conference yesterday. And the Thistle, which is we'll call it our sister supervised injection facility in Scotland, would say that 73% of the drugs used is cocaine in Scotland. So there's a significant difference there, which is something worth probing and maybe examining further. 76% of the people who use this service are male, and 39% are between the ages of 35 and 44, and 91% between the ages of 25 and 44. I won't go through the visits by day. We open in the morning from, you might just go back to some of the statistics, please, on the overdoses, which I'd like to share. We would find that we open from 8:30 in the morning, close at lunch, and then open from 2 p.m. till 7 p.m. And there are obviously periods throughout the day that are busier than others. But just to give you an overview of some of the key statistics, during the months from December to July, we would have had 122 interventions of non-fatal overdoses, and they would have been dealt with in a combination of either naloxone or oxygen therapy. And I think what's really important is the ambulance call-outs. Traditionally, people who might have used the service of Merchants Quay, the needle exchange, may have left the needle exchange and gone around the corner to one of our streets to inject. And in situations where overdoses occurred, the ambulance service and Garda Síochána were called, and it was quite a chaotic scene. And since we opened the facility, we've had one ambulance call-out. The ambulance service themselves have confirmed that the supervised injection facility has significantly reduced the impact on their services. So it's very important when we talk about the supervised injection facility and how it's there to support people who inject drugs. It also has a consequence for the wider public health system. And reduced ambulance callouts is just one example where much needed resources can now be, I suppose, allocated to other areas of the health service. So we're very pleased with the success of the facility so far. We know from our engagement with our clients that they feel that this is a space that is both respectful and dignified and is for them. And we're very pleased that our objective going forward will always be to be a client-focused and client-centered service. So that's really all I have to say on it. We're very pleased. We're halfway through our pilot phase, and we are confident that when the evaluation is completed, it will demonstrate that this is a very important aspect of drug treatment services that should be mainstreamed and rolled out, if I'm honest, across other communities where there certainly is a requirement for this kind of a service. So thanks very much. I would say one last thing. Andy mentioned the partnership with ISCA, and it has been key to the success of this pilot so far. and we look forward to continuing to work with ISCA to mainstream this going forward. Thank you very much.
Thank you, Eddie, for that overview of the MSIF. And I guess my takeaway from it is the aspect you used of the life-saving nature of the medically supervised injecting facility and the need for data, because data drives change. And I think looking at your data, it demonstrates clearly the need for such a facility within the region. Thank you so much, Eddie. I'd now like to introduce Dr. Des Crowley, clinical lead for HSE CH09, and Dan Jacobs from ISCA, and they're going to provide an overview on the naloxone training provision, which was done in partnership with the HSE services in DNCC, my apologies, in DNCC, in collaboration with ISCA. Thank you, Des, and thank you, Dan.
Hi everyone, my name is Des Crowley and I'm Dan Jacob from ISCA, and we're presenting this morning on a project that we have been running in Dublin North City and County for probably about 18 months now. So our service is the opioid substitution service, and in Dublin North City and County, we have 10 satellite clinics where people come into our service and they go to community pharmacy to get their medication, mostly methadone or buprenorphine. We have 6 dispensing centres, and they're larger centres dispersed around the city and county, and that's where people get methadone dispensed on site and other medications as required. And then there is also 3 residential units as part of our service, the Barrymore, which is one of the only stabilisation units that we have in the country, and we have Coolmine and also the Lantern, which is a detox service. So that's kind of our service in a nutshell. Next slide, please. So we have 1,486 people on methadone, and we have 148 people on buprenorphine. We also have level 1, level 2 GPs who provide OST treatment, and of people in the primary care, we have 59 on buprenorphine and 876 on methadone. So in total, we have roughly 2,569 patients. What we are seeing is that the increasing numbers of people on buprenorphine, particularly the new long-acting buprenorphine, and I think we will see the service pivot towards that over the next number of years. I think one of the good messages about buprenorphine, I think it is slightly safer than methadone in terms of overdose. There's a lot of benefits to methadone as well, and evidence would suggest that retention rates are slightly higher with methadone. But I think it's good to give people choice regarding their OST, and also for people to understand what's the positive and negatives about each approach. So next slide, please. So the care that we provide, it's multidisciplinary. So we have doctors, nurses, pharmacies, counsellors, outreach workers, RAS workers. And I think pivotal to our service is the general assistant role. And that's the person that the patient meets first when they come into our service, and they run the waiting rooms and they take drug screens. So they have a pivotal role. And this project that we ran was looking at that particular role. And I think it's kind of been accepted that that role is probably underutilized. And certainly, you know, there has been moves to try and make it more of a key working role, and it's within that context that we felt that role would be very suited to doing some peer working and developing the naloxone training and the rollout of that service. We also work with other agencies through service level agreements, and they're really, really important. Interagency work with the homeless services. In our area, we work very closely with ISCA and with and Lithia and with Chrysalis. So all of the kind of joint up work is important. We have for many years, and we have increasingly advocated for the lived and living experience in terms of development of our service and implementation of new projects. We have a service user on our CQSC, and we also have them on operational meetings at quite senior level. And we've also developed a community where we have half HSC staff and half people coming from lived experience or peer experience. And we're kind of implementing some change regarding how we deliver services through that committee. Again, pivotal to this project was our partnership with ISCA, and again, particularly Andy, but also Andy's staff, particularly the peer educators. We'll talk a little bit about that in the next slide, I think. Okay, next slide. Again, I'm just going to go quickly through this because I think it's really important to understand that it is a huge public health issue, drug-related overdoses and fatal overdoses. 354, I know that's a reduction, but we'll have to wait to see whether that trend continues, because it might just be related to COVID or it might be just a blip in the statistics. So hopefully it is a downward trend, but we'll have to wait and see until we get the new statistics. I think importantly that Dublin is one of is the highest area in terms of the national profile, and Dublin North City and County is particularly high with nearly 20. I can hardly read that. Nearly 29% of drug-related deaths occurring in our area. Again, a lot of the speakers have made this point. Opioids are implicated in 70% of cases. 36% methadone and 22% heroin. Polydrug overdoses are the 81%, and again they're usually in combination with heroin. And it's important to understand that the naloxone component is the bit that reverses the opioid, not the rest of it. But if you reverse the opioid, there's a good chance that that person will actually recover, particularly if they go to hospital. And also that there is more than one opioid implicated in terms of a mix of heroin and methadone and other substances. I think one of the points that we made a few times in terms of the number of people who die alone, which is roughly, I think, 41-42%, and while that's a very alarming figure, I think on the reverse of that is that 58% die with somebody present or die with somebody that potentially might be able to use naloxone. So I think from the point of view of it managing it in a public health way, I think we need to look at that as an opportunity. Yeah. Next slide. Okay, so this was the slide related to the alone and not alone. Yeah. Yeah. And again, Dan, you work in the homeless accommodation, so I was surprised at the 10% figure. Actually, I thought it would be higher in homeless accommodation.
Well, I'm the representative for the clients in a hostel where I live. So we are still struggling. The number is starting to decrease now slowly because people are being more aware of addiction and the problems that come with it, where a few years ago, between 5 and 10 years ago, we were really stigmatized and everyone thought bad about people that use drugs. But social media and doctors that are going on platforms and they show people and people are starting to listen that addiction, it's scientifically proven now that the majority of addictions are based in trauma. So we have to address that issue. With all that happening, people are more willing to access naloxone. And with that being said, a lot of them go to the methadone clinics. So people in homeless accommodation, they will be in a high number of them will be accessing methadone clinics. One of our programs in Ishka that we have, it's going in methadone clinics.
Yeah, I think we have that in later slides. So maybe we'll just talk about that when we get a bit later on. Yeah, so I think we'll just move on from there. But again, I think it is important to understand that the majority occur in private dwellings, and the majority of people do not die alone. Actually, there is somebody present at the time of the overdose. So this is the bit that the bit that you've been talking about again in terms of the peer-led education with people who use drugs. And I think there is documented evidence that it's quite effective. It reduces the barriers with the service and the service user.
So peers are probably almost they can't be dispensed. So they're very important in the work that we do. So there are peer team leads, peer team teams lead out on outreaches, targeted outreaches, and try to break down the barriers between service providers and people who need it.
Yeah. Also, I think there's quite a few benefits for the peer educators themselves as well.
It's once before you start working in an environment, you're gonna get training and things like that. So peers can then educate further out people in need.
Yeah, because I think that was crucial for us. So we had tried a few times to get this project up and running.
Yeah.
And when we included the peers from ISCA, it totally changed the dynamic. And the big thing that changed for us actually was the engagement of our service users. So it felt to us like you were speaking a language and that they understood the messaging,
Yeah.
and then they were much more likely to engage in the actual naloxone training component, which was actually provided by our staff.
So what I can see with that is people they're more reluctant to speak with service providers than to speak with a peer of them. We've been there in the street. We've done all they do at the moment. Some of us still do. So it's not a fight between us and them.
Yes. Yeah.
It's us as a full environment. We're all part of the same society, so we should all be included.
I think we're being asked to hurry up here, Dan, so we better keep going. Okay, so just an outline of the project. So the way we manage it is that every one of our clinics now has what we call an naloxone ambassador. So that comes from the GA.
Yeah.
They have been upskilled and trained to provide the training, and they work alongside 6 peer educators that come from ISCA. That includes Dan and a number of his colleagues. We have an oversight committee that Andy sits on, and that's where we discuss any kind of systemic blocks and barriers. And that's been really, really effective because there's real commitment from senior management to get this over the line and to support it. And anything that has come up, either we have dealt with it in terms of the HSE or Andy has dealt with it. And that level of trust and interagency work has been really, really good. And we do think that it's now embedded, and I think it is a model that could actually be replicated.
Oh, it's definitely ISCA already made a peer toolkit for anyone that wants to access it, but us with the peers going in the naloxone clinics has been a success. Over 700 people trained and received the naloxone.
Yeah.
And mathematically, if you're going about it mathematically, from those over 700 people that took methadone, that took naloxone with them, so many of them already saved somebody's life.
Yeah. And again, on the positive side of that, for us now, it's business as usual. So it's not like kind of a novel pilot that's been set up. It's embedded when we review in our multidisciplinary team. We have a section where we discuss the naloxone training and if naloxone has been used or distributed. And what's really exciting for us is that we're now putting it into our patient information system, which is an electronic system, and hopefully we'll be able to extract data in terms of the number of people who have been retrained and number of people who
we started every time we do a training for somebody in a clinic or in ISCA or wherever we have targeted outreach, and we do naloxone training, we ask every person, have you ever used it? And we take that information back and send it to the HSE.
Yeah. So I think it's important for us locally to be collecting that data. So I think that's us, Dan. Sorry, we've overstretched our time, but again, I think we've dealt with it. There's acceptance, the GA role in terms of the expansion, reduction in stigma. So I think that's pretty much it all covered.
Right.
Thank you.
Thank you.
Thanks, Des. Thanks, Dan. It demonstrates very clearly how what has been said earlier from Andy, how the involvement of the voice of the peer and the partnership approach between both ISCA and DNCC has really clearly moved this program quite significantly along and involving all members of the MDT. And as you said, Des, to those who meet and greet at the very initial phase of everyone coming to services within the addiction treatment services. So thank you so much for that, Des and Dan. On that note, I would like to move over to invite Danielle Tormey from Anna Liffey Drugs Project and Yasmin Woods from Kundara Inpatient Addiction Treatment Centre, who are going to share their experience and how they moved with and facilitated naloxone circle peer training to peer overdose prevention programs within their organizations. Thank you so much, Yasmin and Danielle.
Thank you. Sorry, 2 seconds.
Perfect, girls. That's up now.
Thank you. Perfect. Hi, my name is Danielle and I am a project worker with the Anna Liffey Drug Project, and I'm also a facilitator for the Circle peer-to-peer overdose prevention training.
And my name's Yasmin Woods. I'm a nurse prescriber in Kundara.
So the Circle program is a skills and education program which aims to train peers to become overdose prevention workers. So the Circle represents the circle of peers who can use their lived experience to help and understand other peers and in order to prevent overdose. So the Circle consists of 5 training sessions, and it trains peers to recognise who might be at a risk of an overdose, how to take steps to prevent an overdose, how to effectively manage a situation where someone is having an overdose, and then how to signpost people to services for support in the aftermath of a non-fatal overdose. And this also includes administering naloxone and chatting to their peers about naloxone as well. So I facilitated 2 Circle programs in the community in the Anna Liffey Drug Project in 2024 and 2025, and we had 12 people graduate from those Circle programs. And then in July this year, I went into Kundara to co-facilitate the first Circle program in residential treatment centre in Ireland.
I'm just going to briefly explain what Kundara is and then the benefits of rolling out the Circle program in Kundara. So Kundara is a 14-bedded inpatient unit on the grounds of Cherry Orchard Hospital. We're currently moving to St. Lomans to allow greater patient capacity. We're HSE funded Tier 4 residential treatment centre. So we offer 2 programs. The first one is a 4-week program for stabilisation clients, and that's to detox off street drugs and stabilise and prescribed medications only. And our second program that we offer is a detoxification program, and that's to detox off prescribed medications such as opiate substitution therapy, benzodiazepines and alcohol, just to name a few. We also offer stabilisation program and specialise with pregnant persons who use drugs. We are a multidisciplinary team here. We have nurses, counsellors, general assistants, psychiatrists, consultant psychiatrists and registrars. We have an on-call system as well for any medical emergencies, and we have nurse prescribers here also. So the benefits of rolling out the Circle program for peers in residential treatment settings that we've noticed so far is direct overdose prevention knowledge. So many of our clients have histories of high overdose risk, particularly after detox when the opiate tolerance is greatly reduced and after leaving treatment. This is a very vulnerable period for our clients, and part of our focus is on helping clients to move on to further treatment to strengthen their recovery. Also, it's peer-led credibility. So one of the most powerful aspects of the program is that it is peer-led, and often clients respond better to peers who have lived experience as opposed to clinical staff. It also opens conversations for real-world relapse risks and normalize talking about overdose prevention instead of leaving as a taboo subject. Thirdly, empowerment and confidence for our clients. So people in recovery often struggle with feelings of powerlessness or being defined by past mistakes. And having the Circle training gives clients treatment not only stronger, to leave treatment not only stronger themselves, but also with a skill that is practical and socially valuable and can rebuild self-worth and create a sense of purpose, being able to have a life-saving skill. Fourthly, relapse survival safety nets. So we know relapse rates after detox can be high, and with lower tolerance, even a small amount can cause a fatal overdose. So having naloxone and the confidence to use it not only increases survival chances in those few critical weeks, but it also reduces stigma about carrying it, which we noticed clients had at the start of the program. There's stigma about carrying naloxone with them, and that changed by the end of the program. So thanks to the program now that more clients on discharge are opting to take a naloxone home with them, and they see it as a safety feature as opposed to a taboo. We also noticed the extended harm reduction into the community. So the clients that get the circle training here in Koundara, they don't only get the knowledge when they're here and it stops in Koundara, it actually filters out into the community, into their family and friends as well. So the training here goes a very long way in spreading awareness and preventing overdose. And lastly, breaking down shame and isolation. So finally, the group set encourages open discussions about overdose, which reduces shame and stigma around relapse. This makes it much more likely that a patient will engage with staff should they have a lapse or a relapse, rather than using alone in silence. So altogether, the Circle program builds knowledge, empowerment and safety both inside and beyond Koundara. It complements our core treatment goals and gives clients another layer of protection and strength on their recovery journey. And I'll give you back over to Danielle.
Perfect. So from facilitating the Circle program in the community and then coming in to do it in a residential treatment setting, we noticed some key differences between the two. So the first one was that the Circle program in Koundara reached a different cohort of peers who might not have been linking in with services like the Liffey before, and therefore might not have gotten the opportunity to take part in a program like the Circle program. So this brings naloxone and overdose training into people's lives, and more importantly, into people's communities where it might not have permeated before. And therefore it increases knowledge and availability of naloxone across the board, which is so important. Secondly, the Circle program is peer-to-peer learning at its core, and it recognises people who use drugs as experts by experience. The clients who were in Koundara were further along in their recovery, but this offered the group a unique perspective and feedback which was different but equally valuable compared to in the community. And this allowed us as facilitators to develop a deeper understanding of the challenges faced by peers in different stages of their recovery. And then we could share this knowledge now with future Circle programs and groups going forward. And then finally, clients in a residential setting are in a safe environment, and therefore their focus is on the group and on the content. So in the community, obviously, sometimes life can get in the way sometimes, which can impact engagement and attendance. Whereas the setting offered by Koundara was a safe and respectful environment, which allowed peers to fully engage with the content and reflect on their experience and contribute meaningfully to group discussions without any distractions or stressors. So the theme of this year's Overdose Awareness Day is Communities Driven by Hope. So by rolling out the Circle program in different communities is so important to reduce the risk of fatal overdoses in every community across Ireland. Every person who takes part in the Circle program creates a ripple effect as awareness about naloxone continues to grow, increasing the availability of naloxone and knowledge about naloxone. Naloxone is a valuable life-saving tool, but it only works if there's someone there who has naloxone and is able to use it. So because of that, I want to say a huge thank you to each and every single one of our peers who took part in the Circle program throughout the last 2 years in the community and in Koundara, who are going out into their communities and spreading the word and saving lives every single day. These are all amazing. So thank you very much.
Thank you.
Thank you, Yasmin and Danielle, for that presentation. I found it really interesting that we've now hit another cohort with regards to residential care settings, that that cohort is not seeing this as a negative with regards overdose prevention, overdose experience, and also the fact that you're able to bring some of the learnings from LDAP across into Koundara. It's a really interesting, and I think an area that for a number of years that we've been trying to target, and it's fantastic to see that in operation and being a success within the residential care setting. Thank you both. On that note, I'd like to introduce Aoife Smart, who's head of the Residential Addiction Services in the Peter McVerry Trust. And as part of the whole community piece, it's to how the experience that the Peter McVerry Trust had in facilitating naloxone training and provision of naloxone for residents within their organisation. Thank you, Aoife.
Thanks for the introduction, Dennis, and hello to everybody involved in today's event and for those watching behind the screens. So my name is Aoife Smart. I'm a head of residential addiction services with the Peter McVerry Trust. I have been with the organisation now near to 10 years, so I'm absolutely delighted to be a part of this really important webinar this morning, and I suppose in light of Overdose Awareness Day and Community Driven by Hope. So I suppose So just to give an introduction of the services that I have primary responsibility for would be the Residential Stabilisation Service Barrymore House, as Des touched on earlier on, and the Residential Community Detox and Treatment Service down in Garristown, formerly known as the Lantern, and our drug-free supported housing service as well. So just to give an introduction to our teams, and I'd like to just say a huge thank you to all the management and all the staff that work in Peter McVerry Trust, and a huge thank you to Jenny and Andy and Dan for your collaboration and support over the last couple of months, because I suppose in light of the team community, we wouldn't be able to do the work that we do without everybody's collaboration and support with our clients every day in frontline. So our Director of Nursing and Addiction is Noelle Woods, then you have myself, and then you have Emer McGarry is the Manager of the Residential Stabilisation Service Barrymore House. Then you have Rona O'Connor, Clinical Nurse Manager of the Residential Community Detox, and then Jenny Daly is the Manager of Drug-Free Supported Housing, and Kelly Murphy is the Team Leader of Drug-Free Supported Housing. So their numbers are up on the screen should anybody ever need to reach out for any support in the future. So just to touch on what the services involve and what they entail. So the Residential Stabilisation Service Barrymore House is located on 217 North Circular Road. The service offers a therapeutic and safe space for individuals to stabilise their substance use and return to their optimal level of functioning. The service provides a 5-week residential programme where individuals can learn to lead a drug-free life while stabilising on the prescribed medication. And just to touch on, I suppose, the beauty of Barrymore, what Des mentioned earlier, is that there wouldn't be many stabilisation services available in the country. So I suppose it's a really valued service, and we always have our beds full. So the service can accommodate 12 participants at any one time, both male and female. The programs that are offered would be OST stabilisation. The service does not support a methadone or any nature of opiate substitution detox. It offers an alcohol detoxification, a benzo detoxification, and stabilisation on medication as well. Cannabis and cocaine, crack cocaine, cessation, and any other substance proving problematic. So I suppose what we did in early this year, February 2025, all our management and nursing staff, including Balsama and Ruby at Barrymore House, successfully completed Train the Trainer in naloxone facilitated by HSE naloxone lead Jenny Smith. This initiative aims to ensure that every participant in stabilisation is provided with intranasal naloxone upon their discharge, whether it be that they complete the programme in full successfully or whether they leave prematurely. All nursing staff now facilitate monthly rolling group sessions with participants on the administration of intranasal naloxone. In addition, each individual will then receive a one-to-one refresher session prior to their actual discharge from the service. And I suppose since the rollout in February, I can successfully say that we have provided 60 participants have received intranasal naloxone training and have been dispensed a supply on their discharge, to include both completions and premature discharge. And that would include the new strain of naloxone Ventisol as well. So then in our drug-free supported housing service, it's made up of 12 STA services across Dublin with a capacity of 65 participants. The drug-free supported housing service is one of a few projects in Dublin offering drug-free housing for people making a genuine commitment to recovery from drugs and alcohol,
and who would otherwise find themselves homeless after completing a residential treatment programme. The properties are managed through visiting support. All residents are required to attend and partake in weekly house meetings, provide urine analysis, and ensure that health and safety is being upheld within each property. Each house is in a quiet residential location in the Dublin area. All participants are required to attend a full-time day programme to support their recovery. Staff and management attend monthly case management meetings with drug-free day programmes to discuss participants' progress and identify where further support is required. All participants receive key working, progression support, aftercare, weekly and social nights as part of their programme and maintaining recovery. So in terms of the collaboration with Ishka, with Andy and Dan, and then our collaboration with Jenny in the HSE, we had a huge success and a great turnout with having a session of naloxone training, peer support. So it was delighted to see that the Circle programme was coming into Peter McVerry Trust as well. So we had a lovely morning up in Berkeley Street where our participants of drug-free supported housing all came and they received the training in naloxone. The training was delivered in collaboration with Jenny, as I said, and Andy and Dan. I really appreciate your support, and I suppose we will continue to do in the future. Participants were also introduced then to Ventasolve as well as the intramuscular, which is the new addition to the range of naloxone products. And then I suppose we strive to continue supporting harm reduction and overdose prevention through education, collaboration, and community empowerment. And I suppose really when you think about community driven by hope, why does community engagement matter? So for us, a huge part of it will be peer-to-peer education in terms of our individuals often share knowledge with each other, creating a ripple effect that spreads harm reduction strategies organically. And I suppose in our drug-free support housing, we do have a peer support worker. So we really do value that collaboration there. Builds trust and collaboration involving local groups, peers, families, fosters trust between healthcare providers and community, making services more approachable and effective. Increases awareness and reduces stigma. I know stigma was a big focus on today's session as well. So engaging in the community helps normalise conversations around opiate use and overdose, breaking down stigma and encouraging compassion. So I suppose it's just to say a huge thank you to those organisations. I think if you were to think about community, we couldn't do the work that we do without everybody involved. So a huge thank you to everybody involved in bringing our supports together to support our client group every day. So thank you very much.
Thank you so much for that, Aoife. It's fantastic to see the rollout of naloxone within the Peter McVerry Trust. And also what I really liked was that for discharge, that a naloxone is also provided to those patients after having that peer-to-peer education. And it seems to me that the whole involvement of the peer and how the peer interacts with other peers seems to be the kind of golden nugget of all of this. Thank you so much for that, Aoife.
Thank you.
So I'd now like to introduce Dr. David Joyce, who is the Acting Executive Clinical Lead with the Irish Prison Services, who's going to provide an overview for us on the overdose prevention programs within the prison community. Good morning, David.
Good morning. Thank you, Dennis, for the introduction, and good afternoon, everybody. It's past 12 o'clock now, so good afternoon. And thank you to my fellow speakers for their insightful presentations so far. So yeah, as Dennis says, I'm going to give you a brief overview of overdose and drug use more broadly in prisons and what we're doing to tackle that situation. So for context first, just can we go back to that slide? Sorry. Go back to the, that slide, perfect, yeah. For a bit of context, the prison service, we operate 13 prisons around the country. And as you probably heard from the media, we are currently in the midst of a very severe and significant overcrowding crisis. As of the middle of August, we had over 5,500 prisoners in custody, and that is, we're operating at 119% of our capacity. So the overcrowding crisis is really hampering our efforts to get on top of drug use in prisons and is exacerbating the problem in prisons, unfortunately. Also, it's worth noticing as well that for 446 people, their reality this evening will be that they will not have a bed to sleep in. They will be sleeping on a mattress on the floor beside somebody else's bed. So next slide, please. Next slide, please. Thank you. Yeah, the custodial period is recognised as a high-risk environment for overdoses, and here are some of the reasons why. I mean, first of all, we're dealing with a condensed population of drug users. Estimates vary, but it's probably likely that somewhere between 70 and 80% of people coming into custody have a substance use disorder, and many of those continue to use drugs while in custody. Prisoners tend to use drugs somewhat differently than people in the community. Prisoners I've spoken to have talked about how obviously the main focus of using their drugs is to feed their addiction and to prevent withdrawals. But they also talk about, instead of getting a high or a buzz from the drugs, they're looking to alleviate boredom and to pass the time, and just for the time to pass quicker in prison. People often find it hard to believe that there could be social isolation in prison, but actually prisons are incredibly lonely places. Prisoners are separated from their families, from their loved ones and support networks, and it can be, that can give rise to risky drug-taking behaviour as well. It cannot be overstated how many varied ways that overcrowding exacerbates the drug use and overdose problems in prison. First of all, the overall misery of being a prisoner is increased, but also more prisoners means more avenues for drugs to get into prisons. It also means that the staff on the ground are really stretched. So trying to prevent drugs getting into prisons, it can be really difficult to do when you're working in a staffing model that is stretched compared to the amount of prisoners. And then support staff, so your healthcare staff, your educators, everybody is struggling to meet the demand, and the resources just aren't there at the moment to meet the demand of the ever-increasing number of prisoners. And the next 2 points there kind of take them together. So drug supply in prison is not linear. It tends to come in peaks and troughs. As you've probably heard recently, that there was drones dropping drugs into various prisons. That can suddenly lead to a kind of a glut of drugs in the prison market. But all it takes is for maybe the prisoner who's orchestrating that to be moved or to be released, and suddenly that supply of drugs can stop quite abruptly. And what you find then is that people's tolerance to drugs can fluctuate. Or there might be several weeks where they can't access drugs, and then suddenly they can, and they might overdose quite easily in that situation as well. We've also found that because, again, the drug supply is difficult, that people might substitute and mix and match their drugs. So somebody who might have a benzodiazepine addiction, for example, might not be able to source benzodiazepines on their landing, but there might be somebody selling heroin on the landing, and suddenly somebody who's never used an opiate before is smoking heroin in a prison setting, and it's again a very risky environment for overdoses there. We also find that prisoners tend to favour the more synthetic and more potent drugs. So we've had a lot of issues with nitazines and some other recent potent benzodiazepines coming into drugs. Obviously, the more potent it is, the smaller amount you need to smuggle in to get the same desired effect. It's also worth noticing as well the tragic and well-documented occurrences of overdose upon release, especially in the first 2 weeks after release, seen as a kind of danger zone period. And that's generally prisoners who may have been abstinent from drug use during their time in prison, and then upon release they revert back to taking drugs, and they might go back to taking the same doses they were used to taking, not realising that their tolerance may have dropped. So, and that's unfortunately more common in our more vulnerable groups, so prisoners with co-occurring mental illness or intellectual disability, or female prisoners. Next slide, please. So it's quite hard to draw health-related data out of prisons, but here are some of the trends we've put together. And we've kind of upped our game in the last year. We've had the amount of overdoses have increased, so we've had to up our game in terms of our data collection. We are now maintaining a log of all overdoses since last August. So there's been 87 overdoses recorded since last August, but and there's other information being recorded as well, as along with naloxone use, the presentation, because it can vary quite a lot of those overdoses, and the suspected drugs that are being used and the outcomes. So was naloxone used? Was oxygen used? Was the prisoner transferred to hospital? These things are now being recorded since last August. As you can see there, in the last 10 years since naloxone came on stream, our usage has gone up dramatically. That does in part mean there has been more overdoses, but also the flip side to that is that there's more overdoses being recognised and treated. We have more availability of naloxone. All of our prisons are fully stocked with naloxone, and we have more people who are trained up, experienced and comfortable in administering naloxone as well. And also accounts for some naloxone that's given to prisoners upon release, so more about that later on. And then our emergency department referrals are a good way of tracking the really severe overdoses. So people required to go to hospital with their overdoses. And in the years, those 2 years there have been 75 of those, 13 of which were associated with one incident in one prison in one day. Next slide, please. So what are we doing about it? I suppose the first thing to mention is that the Irish Prison Service is working under a comprehensive drug strategy of our own, the IPS drug strategy, under the 3 pillars of inform and educate, detect and reduce, and support and treat, as you can see there on the right-hand side. Probably one of the most invaluable things we've done in the last year and a half on foot of that drug strategy is to appoint a national clinical lead for mental health and addiction. And she has really progressed IPS strategies in terms of data collation. We've mentioned from previous speakers that data is key in trying to understand the problem you have with drug use and overdoses. Sharing data and learning from other organisations and jurisdictions, and kind of improving governance over the treatment modalities that we offer to prisoners. It is worth noting at this juncture that there are some impediments to reporting overdoses in prisons. First of all, is the issue of not all overdoses present alike. It can be quite hard to tell when somebody tips the balance from intoxicated into overdose, and also many of our overdoses, the majority of our overdoses, would be your typical respiratory depression and reduced level of consciousness. But also, when we're dealing with the likes of synthetic cannabinoids, the exact opposite is true. You might have somebody who's overdosing, but they're actually really erratic, really aggressive and violent, and that can also be extremely dangerous for their fellow prisoners and staff in that setting as well. And then there are issues with prisoners potentially not reporting overdoses, and the reasons for that can be that not that they don't want help or that they won't get help, but sometimes they feel that if they report that their cellmate, for example, is having an overdose, that might then lead to the cell being searched, or indeed the landing being searched and contraband being seized, which could make them very unpopular with their colleagues. So there can be some reticence among prisoners with regards to reporting overdoses. Next slide, please. So just in terms of what services are available for prisoners in prison. So every prison has its own primary care and psychology teams, which are adept and experienced in dealing with addiction. They are good at identifying prisoners who are at risk of overdose. They're good at identifying the overdose itself and treating that and responding to that, and also the aftermath, because overdoses, especially serious overdoses, can have a serious effect on the prisoners behind. So there's also worth noting that every closed prison has opiate agonist therapy clinics, and we are expanding our choice there for prisoners in those clinics as well. So they have options, including the long-acting buprenorphine, and we're really working on having good community linkage, so that when they get released, there's no lapse in care. They can transition seamlessly back into community. From our friends in MQI, they provide addiction counsellors to our prisons, with 20 addiction counsellors who've seen 804 clients in the first half of this year. There's an addiction manager, and there's also the TARP program, which is an intensive drug treatment program in Mountjoy Prison, an 8-week program. We also have other in-reach services worth mentioning: AA, NA, Samaritans, the Recovery College, and a particular word of mention for, if you go to the next slide, please. Particular word of mention for the Red Cross. So these are probably our most effective way of getting information and overdose awareness strategies to our prisoners. So they are peer-led, as we've heard so many presentations today. Peer-led is key and really, really valuable. They are prisoner volunteers who are trained up to provide peer-led education sessions and information awareness sessions to their fellow prisoners, focusing on overdose recognition, risk factors, and response. And they're really, really good for kind of information campaigns and posters, like you can see there on the right-hand side there. They recognize that Christmas was a danger time for prisoners overdosing, so they put together that very effective poster there as well. As I mentioned earlier, we are working on trying to provide naloxone on release for high-risk prisoners. So they're identified during their sentence. They are provided with training and how to recognize overdoses and use naloxone. And then upon release, they are given a kit to bring with them upon release. Uptake has been slow, and we're looking at trying to diversify that, because not all prisoners, it's not the first thing on their mind when they're going out the door of prison. They're more excited to see their family as opposed to calling in to pick up their naloxone. We also have closer links, and we're very grateful to Professor Eamon Keane and his team in the National Drug Treatment Centre, because we now have links with those. So when we do come across a substance that has been associated with an overdose in prison, we can get that tested rapidly. That helps us to know what we're dealing with, helps us to tailor our response to any more overdoses, and to tailor the information provided to prisoners. And last slide, please. So next steps. I mean, today is brilliant. I would love to see the likes of today being replicated for prisoners. So expanding the amount of overdose awareness training that goes on in prisons, including staff in it, including prisoner families and loved ones in it as well. Naloxone training, naloxone has been a game changer for those who are suffering from an opiate overdose. So any more ways we can bring in naloxone training for prisoners, staff, and again, families is we're open to listen to all ears. We were happy to engage with all our colleagues in the HSE and wider Department of Health and Justice. We were actively trying to learn from other jurisdictions to see what other prisons are doing in terms of addiction treatment and overdose prevention. We've had visits to other jails to see what they're doing in other jurisdictions. And if there's one thing I've learned as the clinical lead for the Irish Prison Service, is that you need to diversify your treatment options for addiction and for overdose prevention. So just as there are many different paths that lead people into drug use and addiction, it figures that there are many paths out of it. So we are really, really keen that we don't just try and use one treatment modality for everybody. For some people, it's one-to-one therapy. For some people, it's group therapy. For some people, it's faith-based. Other people, it's pharmacological-based. And the same goes for information campaigns. We're trying to use all the media available to us. So we're trying to use our education centres, our healthcare providers, peers, in-reach speakers, posters, leaflets, whatever it is. The more different ways we can get information and awareness out there and treatment modalities out there, the better. So if I can say one last word, is that when it comes to treating addiction, one size does not fit all. Thank you very much for your attention.
Thank you so much for that, David. Most especially from my perspective, since 2015, seeing the movement and the improvement in the provision of naloxone, and also the whole piece around the involvement of the Red Cross with regards peer involvement, and also the training of those in prison with regards overdose and overdose prevention. So thank you so much for that. So I'd like to thank everyone for remaining with us today. I appreciate we've gone over time, and I'd like to just say that thank you all for coming here today. That brings us to the end of today's webinar. As I've said earlier, it has been recorded and will be available on a link to listen to. It will be shared on an email post this event. I'd like to thank everyone who joined online today. This helps raise awareness about overdose and acknowledge the lives lost and the grief experienced by loved ones, friends, family, support colleagues, volunteers and peers. The sub-theme of this year's IOAD was community driven by hope. We heard today from many experts across the spectrum, across various communities, most especially from our peers, and how peers have become integrated into the development of how services should be provided to other service users within our organizations. We've heard how many times naloxone has been used and how an invaluable intervention it has been seen. There's a very powerful message of learning and incorporating those who have lived the experience, and how peers have become continuous respected advocates for change within policy. We've also seen how peer-to-peer overdose prevention through the Circle program and the benefits that is seen from that. We've seen the amazing partnerships and leverages on learnings with the HSC, the Peter McVerry Trust, Kundara, and the involvement of ISHCA and the National Social Inclusion Office. The utilisation of the peer experience and the voice of the lived experience is invaluable to ensuring the success of any program like this. I would also like to acknowledge that the Circle program is a national rollout of the Novus Topple program, and I'd like to take the opportunity right now to thank Novus for sharing the Topple program. Again, I'd like to thank each one of our presenters today for supporting this webinar, to the HSE National Social Inclusion Office for hosting it, IMS for facilitating it, and for everyone in our community who supports a reduction in drug-related harms and deaths and non-fatal overdoses. I would like a special thanks to Jenny Smith for her hard work, her drive and enthusiasm for driving this program forward. Finally, I'd like to thank you for joining us today to demonstrate that as one community driven by hope, we can prevent lives being lost to overdose. Thank you so much.